Hey guys, welcome to Kosi Talks Live. For those of you joining me for the first time, welcome. My name is Kosi Belloso. I'm a physical therapist here in what is now very cold Tampa, Florida. We had a respectable 40 degrees out right now. So that, our winter, our Florida winter. Sitting with me tonight is Dr. Joseph Alderete. There's like a whole list of things we need to talk about with Dr. Alderete tonight, but I'm just going to give him the quick introduction and a chance to say hello. This evening. Thank you so much for being here with us tonight.
Thanks, Susan. Greatly appreciate it.
So guys, those of you who have been with me these past few years, you know that Veterans Day tribute for me is something very special. My own father served in the military for over 20 years in the Army, HUA, 82nd Airborne. So that means he jumped out of perfectly good airplanes for no good reason at all, and loved him for it. And I know that many of you this evening are veterans that served our country in the armed forces. So tonight, I want to hear from you. Tonight is for you guys. I want to say thank you. Very, very special thank you to the men and women that have sacrificed so much for our country and for the freedoms that we enjoy as citizens of the United States. So want to start hearing from you guys. I'm going to start reading out these comments because I want you guys to introduce yourselves to Dr. Alderete. This is his first time on the show, so we got to do the hazing ritual. You got to let us know who you are, where you're from, and more importantly, what is in your coffee cup this evening. So guys, I am thugged out. We are full on 82nd Airborne, 101st. Eat your heart out. That's all I got to say right now. Eat your heart out.
That's awesome, Cozy.
I'm going to ruffle some feathers this evening with this.
Okay.
We got G.I. Jane in the house watching from Facebook. And guys, as a reminder, I am streaming to Facebook, YouTube, and Instagram. We got Scott coming in from West Virginia with cold water in the cup. And he says, thanks to all of our veterans, not for their service, not just this week, but always. Amen to that. We've got Emily coming in from Central PA, Jasmine Citrus Teachers, and says, I was part of a panel of 4 amputees that got to share their life experiences with limb loss at First Medical Center this morning. Great opportunity, and I know they enjoyed hearing the story. I have a lot to share. We've got Chuck coming in from Wyoming with his D. Jane is coming in from Arizona. Ham Sandwich is coming in saying, good evening, good old Fort Wayne, Indiana. Water in my tumbler, and for sure, happy Veterans Day to all those who served and serving. We love the Wednesday night stream. Thank you for being here. We've got Stacy on board. Stacy is my new buddy. She is one of the newer Integrum ambassadors. And if you haven't watched her video, guys, on the YouTube channel, incredible story right there, and just an overall really fun human being. We've got Patricia here in the cold in Florida with her hot tea, Donna from Wyoming. We got Jim from Ohio. Let's see, we got Jane on board again. We got Mike coming in, Doc Mike, Texas. Harsh is on board. He's one of my original viewers right now. Jane is saying, go Army. Jamie is saying, thank you, Dr. Alderete, and all of our veterans for your service. We got John C. coming in from San Diego. Thank you for your service, every veteran. So guys, every year, as you jump on board, again, especially my veterans, if you'd like to let us know which branch that you served, your MOS, if you like, whatever. A lot of our hearts. And also, I do want to say a thank you to Integrum. They've been sponsoring Veterans Day for several years now. They've sent the Army surgeons and naval surgeons. So it's always a good time on the Veterans Day show. So let me tell you about this special guest sitting next to me this evening. So Dr. Alderete, the first thing on your bio, which I love, is devoted husband to Sonny Alderete and father of 2 children. So that shows there. And West Point graduate.
Yes, ma'am.
We're going to be asking you questions about that. Medical school at Penn State College, did residency over in Eisenhower Army Medical Center.
Yes, ma'am.
And then again, staff orthopedic, and then fellowship training again at Mayo Clinic in Rochester.
Correct.
Right? And then you established the osseointegration program at Brooke Army Medical Center in Fort Sam Houston, Texas.
Yes, ma'am.
I'm just touching on key points here. So guys, I was looking at his bio when he was introduced to me, and I was so excited. Brooke Army Medical Center, and a lot of people know about Walter Reed, right? And if you're Army, you also know about BAMC, and that's actually the first place I volunteered at when I was a snot-nosed 14-year-old, and where I fell in love with medicine. So it's nice to see someone who was also did time there as well.
Absolutely. You know, home of the combat medic, the military's only level 1 trauma center. There are a lot of things about any major military medical center where you just need to They need to embrace their vision. They need to embrace the real essence of who they are. It was interesting in the early, 2001 to 2006 cohorts of the Walter Reed and the BAMC competition, until finally there was the understanding that we're the Army's Institute of Surgical Research, the Army's burn unit. We
Yep.
do not have the academic firepower, or did not at the time. And from the standpoint of my Walter Reed brothers and sisters, and I loved them dearly. We were not immediately affiliated with a university medical school. And so that sets different tones. But one thing we did very well is we took care of trauma every day, day in, day out, in a big level 1 fashion, which we shared with the university where I'm at right now. And that shapes a very different experience. So I was grateful for every minute there. I still, I'll get teary eyed as I drive by the parking lot where many nights I would park on the roof and watch the medevac birds or the Aero medevac helicopters, the Black Hawk, come in and land on the roof of this unbelievable military trauma center.
Mm-hmm.
So it's a special place, man. It's special.
It is, and I'm showing my age here. I was working there back when it was at Beach Pavilion, so it was just a 3 or 4 story building, and then a few years later, this big, gorgeous facility that you described that was built there. So incredible. Jane's asking, "Hey Doc, are you airborne?" You can tell who our other 82nd Airborne is around here.
Yes, as a matter of fact, on several levels.
You didn't mention that to me in our previous conversation. Holy cow. So guys, I got the chance to hang out with Dr. Alderete in person at the Gecko conference this past week. And you guys may have seen some pictures about that. Basically, all the biggest brains and nerds of osseointegration were at this one conference, and it was incredible. It was absolutely incredible getting to hear all the different technology and research and collaborations from around the world. So yeah, that was quite the experience there.
Yeah, I agree. Hats off to Joey Shue and the Gecko crew in bringing just a wonderfully collaborative experience to, just solve hard problems and try to facilitate a great experience for our patients. So that was, it gets better every year. They've done a great job.
Yeah. So I want to hear a little bit more about you. What inspired you? Because I think you're my first West Pointer on the show.
No, Joey Shue was
Joey
probably,
Shue.
Yep.
Sorry, Dr. Shue.
No.
So
tell him do more push-ups. It's cool. It's
So what inspired you to go that route?
My dad was a B-29 pilot, and in World War II, he rose from basically bombardier navigator or first lieutenant through captain to full colonel in a period of 4 years because everybody else died. You rose through the command system because the rest of your bomber crew were killed. And he grew up with, dear friend, rumors of Godfather, whatever. Definitely fans being Pappy Boyington, the commander of the Black Sheep Squadron, VMF 214, and everything about selfless service, the greatest generation, these rogue rebel leaders that were just off the charts, incredible humans. In some cases, humans with some significant baggage, because in those days there was no experience that you facilitated out of yourself. So Dad was just his level of unconditional love, but of love for the country, really inspired me. So I never wanted to do anything other than serve since I was 6. And I was a little bit of a neurodivergent gymnast. So had some discipline issues in high school that ended up a couple of times with dear old dad bailing me out of jail, um, which was hysterical. Yeah, so the interview at the academy that happens if you circle yes for have you ever, like I think
Yeah.
my FBI inquiry was 3 pages long. So it was so that was a fun moment. But yeah, I desperately wanted to go to an academy. I saw that it was going to have to come in a non-traditional fashion. So through a little military junior college called Marion Military Institute and enlistment, I was either going to serve through a what they call an advanced commissioning program,
Yeah.
where I became involved with special operations and or enthralled um, with the counterinsurgency, and so at that point, through the Reserve National Guard systems and a green to gold transition, you could get an SF unit as a second lieutenant rather than captain promotable on active duty, and then you could accession on active duty. But as a gymnast, I was kind of broken at the time, like um, just accumulation of a lot of hard training, and I didn't have the talent that many of my elite counterparts did, but I did have a decent work ethic. So at Marion, I would drive out to Montgomery, Alabama, 90 minutes away, train for 3 hours, come back, study until 1 a.m.,
Holy
get
cow.
at 5 for formation. So like 2 years later, I got picked up for the academy, got an appointment after 1 year's worth of refusal, kind of a testament to like just try and keep going and keep going. Yes, ma'am. And the head coach, Doug Van Everen, had been recruiting me for years since I was in high school, as he picked up the Army gymnastics program, which, oh, by the way, this April is 100 years of Army gymnastics. Go Army!
Go Army.
Yeah, man, it's like crazy. I didn't even know anybody knew what men's gymnastics was 100 years ago. But apparently, standing on your heads was not, or on your hands, was not an unusual talent, even then.
I was like, do you and Dr. Shu ever get into that challenge? Who can stand on their head the longest? You've seen his videos, right? The two of you.
I have seen some yoga videos. I don't think he can compete with a Division I gymnast.
I don't think so, but it would be a great video. I think I'm going to put that challenge out there. Yeah,
we'll do it.
Next conference.
Like Doug and the West Point gymnastic team became kind of the truly one of the pillars of my experience. They were, when I was having a tough time, studying, because I was the old guy when I got there, and as the old man, there were, I've got guys like Kyle Potter in my class who I love the dude to death, and a very smart mechanical engineer, but I'm like, I gotta keep up with these young guys. So, whenever I was busting hump in nuclear engineering, trying to keep up with the rest of the class, I could go blow off steam. Coach was just an incredible experience from the standpoint of pretty much everything that I would say shaped a Army surgeon, either combat or university level, was Army gymnastics. Was like digging hard. You're going to have bad days. I was not the most talented dude in the world, but he really admired work ethic. The whole team was like, you're kind of the broken old man, but the fact that you just keep hammering was great. And it was the ability to do Division I gymnastics set up from an academic and an athletic level what became Army orthopedic surgery for me.
I was gonna say, I can see where now the segue towards orthopedics came quite naturally after that one.
Yes,
Uh, and guys, just to brag a little bit about Dr. Alderete, and I was not aware of this point, is that West Point is known for being obviously mainly engineering. They like to crank out their engineers, and I think you mentioned to me that only 10 cadets out of a class of 1,000 go into the medical field.
I think we had my year we may
Very
have had
small
22.
percentage.
Yeah, it was got it. I know the rest of my classmates will shoot me, but I would suggest that it's probably 20 out of our class of around 980. So roughly like 2 to 10% at most.
Wow. Guys, sorry to interrupt. If you are experiencing some trouble watching me on Facebook, go ahead and go over to YouTube. It's a little bit easier sometimes to watch me in YouTube, and you can find me. Just type in Cozy Talks, and we'll pop right up there on YouTube. So, guys, I do apologize. Unfortunately, Facebook sometimes gets a little slow and laggy. Guys, can you just throw some comments into the comment section to make sure that you guys are still hearing us and everything is still good to go? So, you did all these amazing training. You went specifically into oncology orthopedics, right? Is there a particular, you kind of showed up and just fell in love with that side of orthopedics, or what led you towards the oncology side?
It's funny. As the quintessential kind of neurodivergent child, I hate easy stuff. It drives me insane. So I can barely tie my own shoes, and all of my mentors are like, Joe, you can barely sign your charts. But when it comes to inventing just unbelievable reconstructions and just leaning forward to hard things, John Eady was the orthopedic oncologist at Columbia, USC Columbia, that served Eisenhower. At one point, I came pretty close to quitting orthopedics and doing cardiothoracic surgery because I love complex medicine. So surgical critical care. My cardiothoracic mentors were, off the charts. Dennis Nichols to this day is just a person I dearly admire as a double boarded cardiothoracic and vascular surgeon. But those people really shaped you take care of the whole patient. Yes, you manage surgically, but we go to the ICU together and you nerd out on the lab that is a patient in the ICU, and you give every bit of yourself in doing that. And at the time, the war had just spun up. Eisenhower was not an extremely busy place in 2001. I remember being in the resident room when the enemy hit the Twin Towers. So it was, I wanted to have an impact and do really big medicine. And I loved orthopedic trauma, but I saw, like many of my orthopedic trauma colleagues, abdicate the medical management to the general surgery trauma teams. And I'm like, I'm not doing that. So then enter John Eady, who was this larger than life former Wild Weasel fighter pilot. Those are the guys that fly, the F-4 Wild Weasel flies in ahead of the formation with radar blaring, like, shoot me, shoot me, shoot me. And then they go weapon systems off, radar off, and frequently are near dead stick going after the SAM batteries in Vietnam. And so Colonel Eady, General Eady, just off the charts hero human beings. So phase forward later, Dr. Eady was my mentor, in a system, because we go over to USC, Columbia, and do our oncology rotation. And I walk in one night, and Dr. Eady would always challenge me with the most, like, the dude knew everything from molecular science to macro surgery to a lot of materials and engineering. And I'm like, I kind of like this. But I walked in one night and the dude's asleep in a book, 9 p.m. And I'm like, Dr. Eady, sir, what's going on? And he's like, nothing, man. If I'm not like reading to be bigger, faster, stronger than you are, then I need to get another job. And I'm like, I'm gonna be that guy.
I was like, I have met my match right there. There we
Yeah,
go.
so lo and behold, same quality human being. I learned had to get out of the Air Force because he gave his daughter a kidney. I believe that's the rest of the story. Hopefully, I'm not quoting that wrong. But just he was that level of human being. Took care of all his patients from like hair follicle to toenail, ICU to medicine staffs. So I kind of wanted to be that person that very much like I still get into the weeds of my patient's critical care, um, love it dearly. And from that standpoint, only the orthopedic oncologist does that.
No, and we're going to be getting more into that a little bit later in terms of your whole patient approach, really truly the holistic approach there. So how did you get? So you were at BAMC, orthopedic oncology, which we discussed this earlier. Oncology patients make up a very small percentage
Yeah.
of amputee, general amputees. It's only 1 or 2% of those patients. So what drove you to amputee care, and more particularly osseointegration? How did that path happen?
It's kind of interesting. Most of us that do ortho-onc have a passion for amputee care, and we because the nature of what we do, we're very nerdy, and we like giant engineering problems. We generate a lot of amputees ourselves. Sometimes the nature of the beast in cancer surgery is an amputee generating, process. But also, there's always that um, combat surgeon MacGyver of all tasks that the orthopedic oncologist um, continues to foster. Guys like Don Gajewski. I mean, just so Tom Temple, just some incredible people in their service as orthopedic oncologists have been our mentors in the most just incredible combat surgeons. So we take a fairly decent combat mantra in orthopedic oncology. Um, I Most of my deployments have been actually all of my deployments have been um, surging or serving special operations commands of various ways, shapes, and forms. My first deployment was with 3325 or the Triple Nickel, serving 173rd and 3rd Special Forces Group in the Northeast Valley of Afghanistan. And the surgical firepower of a forward surgical team helping the counterinsurgency absolutely blew me away. Obviously, everything from helping Sarah Hussein do cleft lip and palate. I mean, I'm an orthopedic surgeon, and I'm playing with a village elder's kid's face because if she can't marry, then that's not good. So in that it became rather than and Lee Trombetta, who is an incredible trauma surgeon at BAMC, later on into retired practice, set up this incredible um, surgical civilian trauma facility within Fob Fenty in Jalalabad, Afghanistan. And the whole region benefited from it. I mean, the National Medical School that my beautiful Afghan brothers and sisters were trying to set up. Just everything in that area became the understanding that limb salvage and advanced amputee care, partnering with ICRC, had to be something that was going to be passionate for me, and it became, because it was a way to help the operator. It is a way to help the hearts and minds of the population, which I love taking care of indigenous peoples. And then, as like I said, as time went on, my involvement with Center for the Intrepid, I always kid around, that was my kindergarten. Like learned everything there. My patients taught me everything there. My fellow staff taught me everything there. It became, I think, I mean, I'll be a little, um, I guess, a little unobjective in saying that I think the orthopedic oncologist does multidisciplinary care the best of orthopedic subspecialties because we run in big teams and we're like, hey, Cozy, what do I do with this person from a physical therapy standpoint? And we're not afraid to say, like, I don't know anything about nutrition, but maybe, I think I know somebody who might. So in all of that, took over surgical directorship for Intrepid in 2016. Thanks to AJ Johnson and a lot of other folk who are like, Joe's not an admin leader; he's a surgical leader. Foster people where they can grow the most, and I think we did a good job in the 5 years that I was there in standing up advanced limb salvage, amputee care that would and limb salvage care that would earn their way into national and international media. But the limb loss has been, it's the rise, right? It's the rise of the human being. It's it's get your ass knocked down and get up
again
and go.
No, and then you did, so according to, you did 30 years, served 30 years in the military. And recently, well, in my opinion, it's still fairly recent, the past couple of years, retired from the military.
Yeah.
Adjusting.
So, crazy breaks in service. Yeah, it's whether or not the system counts, your medical school and all this funny Army math, whether or not you count your actual West Point service. But anyway, played from 1991 till July of 2023. Loved every minute of it.
Yeah.
There's not a day that goes by that I don't think about putting the uniform back on because I just miss my brothers and sisters.
Yeah, it's a tough transition. I think anybody here who's done military, it's a very, I was only an Army brat. And it's a very, very stark difference. And it becomes as much a part of your heritage as your ethnicity, I think, in many ways.
Yes,
that
I
kind
guarantee
of right there.
You remember running around on multiple posts in the 80s Army.
Oh, yeah.
And it's a pact, man. It's a cult of little kids that carry that with them forever. My wife's the same way. Just cool.
It is. It is. And it's cool to share that then with the next generation and hopefully impart that sense of service and patriotism to the next generation. So moving forward, right now, you are currently at UT Health of San Antonio, director of Mosaic, and you have a beautiful story about that I'm going to let you tell as well.
So when Intrepid is a centrifugal building. It's, truly the last standing isolated building of MATSI at Walter Reed or National Naval, C4 or National Naval San Diego. Intrepid still stands by herself in the ISR, what's essentially the ISR parking lot. And you walk inside and to the left is a beautiful mural mosaic that Colonel Katie Yankovic, who was the then director as I was surgical director, had, I remember going through all of these art suggestions, and there's a local Texas artist that facilitated this incredible thousands and thousands of tile pieces that come together for Intrepid's 10-year anniversary. And it's CFI in a mosaic, so that you walk in um, in, sorry, you, I
When you walk in,
out
no,
to,
that's okay. That's all right. So I
you,
know you.
no, you're good. Well, I was, Ryan Davis, a dear friend of mine, triple amputee, who would throw me on the ground. He's such a powerful judo expert. One of his graduation shirts from ISR said, put together with pieces and parts. I mean, Intrepid's design is you come in semblance of parts and broken, and you're made whole again. And that wholeness is the mosaic. It is there are certain laws. It's mosaic law. There's this beautiful, like, we look like the Black Sheep Squadron. I mean, we're nutritionists and we're physical therapists. There's a bunch of the engineers, like, it's crazy looking. But you come together as this whole team that literally makes art out of broken. So I wanted to bring that name, that idea to San Antonio outside of the military, because San Antonio is not a pinnacle city for understanding multidisciplinary medicine in a dimensionless format. It's really rather interesting. So the appreciation of take that program that I love so dearly, we didn't do a great job of translating. I mean, we, even with all the media, we didn't do a great job of translating what is the essence of Intrepid and this DoD system that is so much the special sauce that enables people to knock it out of the park in their quest for wholeness. So my delusion was, or delusion of grandeur, was take that out of the military and bring it to San Antonio with the help of University Hospital and UT Health.
And it's not an easy task, transitioning. And actually, one of our questions tonight is a really fantastic one coming in from GI Jane. And she was asking, what do you see the difference in, let me make sure I get the wording right of how she asked this question, your experiences with your civilian patients compared to your active duty patients. How, I'm trying to find the question to make sure I get this correct. But how do you find the differences there in treating the two different populations?
It's interesting. My civilian patients through the UT system here in San Antonio have been absolutely fantastic. Everybody of the osseointegration program wants a different life. And in fact, number one is the age of my osseointegration patients. Mm-hmm. So first and foremost, I have a number of just fantastic amputees. I'll use Malcolm Pace for an example. Hopefully he won't shoot me for saying his name. But just an individual who has had off the chart prosthetic care. And I know he would say and echo the same, but difficulties with being a very active Texan in a socket with volumetric changes of a gentleman in his 70s. And, Malcolm, his beautiful wife, would say, I don't have that much time left in order to give back to the world. So I'm not going to spend it in a chair or tripping over yet another difficulty in a painful socket. Mm-hmm. So number one would be age, because I think our over 65 osseointegration population can give back like dramatically. So number one has been age.
And I think you were reading from my notes because that was another question that came in today. Pam, I hopefully you're on board. She said, "What is the age cutoff? I just turned 65." And I said, "Well, this is a great question because I love hearing now that we've had, FDA approval for 5 years in the United States, where we've come since 2020 in terms of the absolute hardline criteria, age being one of them, to now is very different. So how do you, what are you mentioned the Malcolm individual that he's in his 70s. When you have a patient that's 65 or a little bit older, what criteria are you looking at that point to see if they would make a good candidate?
So we're trying desperately to make sure that the bottom line, we're not going to hurt anybody, that we're not going to facilitate a higher level of amputation or put somebody back in a chair. So number one is the individual a steward enough of their own physiology that they can be expected to do the necessary rehab with the necessary patience. So we all, huge fan of Peter Attia. We're all fighting this decathlon for our 70s, and the ability to do it well and continue to impact means how good are you with your nutrition? Are you, are you insulin resistant? That's somebody that I need to work with prior to becoming an osteomodulation candidate. If you're taking your nutrition and your mental well-being and your goals in life, what do I want to do? I'm able to do the rehab from a physiologic standpoint and from a cognitive standpoint. You can follow instructions and continue to knock it out of the park, and understanding that it's a big hurdle. I mean, you're going to be a third slower than the rest of your population or the rest of a cohort that was maybe 20 years your junior. So as long as people understand that I really have to be nerdy about my everyday, and I've got to be strict about my weight bearing precautions, or if it hurts, I'm going to take a step back. I'm going to listen to my body. Maybe I do the nerdy Dr. Alderete wear a continuous glucose monitor because, I want to avoid that inflammatory bomb, but understand that really I've got to grab hold of the steering wheel. And those patients, if you're an 80-year-old and you look like a 60-year-old, and as long as my plastic surgery colleagues, we have such an unbelievable team here, people that I would put my life in their hands. But certainly I ask them to manage my chaos. As long as a team, we feel like the individual is physiologically appropriate, I will not say no.
And I love that approach. I mean, it's more of the quality. How's the individual living their life? Guys, on a quick housekeeping note, I do apologize. Facebook has been a little bit cranky. I seem to have been able to get it streaming again. So if you like watching me from Facebook, jump on board over there, give me a shout out and let me make sure it's working. So we're going to keep moving. And that's why God invented YouTube and Instagram, to allow us to keep streaming. And then on a different housekeeping note, I mean, this is the mark of a good show when you just keep going with the conversation and you forget to announce the giveaways. We do have giveaways because, I love my free stuff, and twice on Sunday. So guys, I've mentioned this on so many occasions. I cannot do this show without the support of my sponsors. Truly, it is something that I rely upon every year. And Integrum has been a faithful sponsor for several years, and I cannot thank them enough for their support of the show, for introducing me to individuals like Dr. Alderete. In turn, over the years, with all of these beautiful connections that I'm able to make, it allows me also to help you connect with some of the top clinicians in the field. So basically, this is my long-winded point of saying we need to show some love back to Integrum. So I know Jamie is going to post for me the handles for Integrum for TikTok and for their YouTube channel. They have some amazing videos on the YouTube channel, patient testimonials, interviews there as well. So guys, please show your support. Don't click out of the show, just right click, follow them on YouTube, follow them on TikTok. And at the end of the show, we're going to pick 2 winners with swag bags. Chuck says it appears to be working again on Facebook. Hallelujah. All right. Yeah. All right, here we go. Now we're going to be cooking with grease. All right. So with regards to, now we're going to kind of backtrack just a little bit, going back to Gecko, right? This big, huge osseointegration conference where you have all the greatest minds of the world in osseointegration there. You know, we got to hear about all the different types of OI out there, and there's a lot of different types. Now, obviously, the Integrum OPRA implant system is the only one that is FDA approved in the United States for above the knee amputees. What drew you to this particular system? And this is an answer I always love to ask all the surgeons that do OI. Like, what drew you to OPRA?
You know, it was really interesting. Jonathan Forsberg and Kyle Potter started the DoD. You know, obviously, John was a Naval Academy grad, former Marine sniper, absolutely bad individual and great human being. Kyle being my West Point classmate, I, as somebody I would consider trying to be a surgeon scientist. So as this was going on in other parts of the world, I was worried about the skin penetration site. In reaction to metal, had seen many different epithelium. So I wanted to watch a little bit. As John started the osseointegration all hands in 2016, I started following. 2017, fully participating and starting to take my intrepid amputees to Walter Reed to participate surgically, because I said, okay, full on boys, I want to learn osseointegration. I'm going to do that in a humble fashion because I know OI is not a see one, do one, teach one. And yeah, it's just like so many stupid things we do in surgical education. But like Kyle and John did this in the most responsible fashion. We wanted to keep the trial homogeneous, so I wasn't going to insist on having my program yet at BAMC in 2017 because there, you know, we would dilute the numbers and do stupid things, and the FDA would freak out. So we kept her there at Walter Reed, and I went, for 3 years, nearly for 3 years, was carrying patients up to Walter Reed National Naval Bethesda, and then finally, and I believe it was 21, we brought the program as an official satellite to BAMC. At that time, through the whole process, I made a decision that the systems that I were going to use were going to have to be an excellent skin penetration site, infinitely revisable, easy to get out without like splitting the femur. And if there were an infection, I could revise and restore with minimal surrounding damage.
Ding,
So,
ding,
yeah.
ding. Like you went above and beyond all my checkpoints, even including the one where the revision, the amount, because we've talked on the show that there are cases where there needs to be a revision, there needs to be some work done, and it doesn't basically eat away at the bone that is left in doing the revision process.
Yeah, Integrums, Oprah and Dr. Brennemark's process, we all spent a long time trying to learn how to heal that full thickness skin graft to the periosteum. The periosteum of bone is such a beautiful mechanism, and forgetting to use that as your factory or nuclear firepower for healing is just it is putting one of your most powerful bone tools away. So that bonded matrix process, many people, if you look the process up, we're creating a full thickness skin graft and annealing it to bone. Jason Souza, one of our plastic surgery partners, basically outlined or championed the outlining through another Gecko conference of what does that skin interface look like? And there is a zone of absolute stability, a zone of transition, and a mobile zone in the tissues around.
Yep.
Once that absolute stability zone of what you're looking at on, I don't know if you can see my mouse, probably not, but
Unfortunately not, but yeah.
it's okay. On far right diagram, in that full thickness skin graft, healing to the periosteum and taking advantage of the periosteal vascular supply.
Yep.
Once that's bone grafted, it is a beautiful skin interface. To me, the most quiet epithelium and the most quiet of what we know of every osseointegration wound, which is an always angry wound. In other words, it is a perpetual wound. We
Yep.
just, I love Jason as he says it, we just have to make it a quiet wound throughout its entirety.
And I've got another video. This is probably one of my favorite videos just because it was just so well done to show what it looks like here with this video. And it's exactly that. I like that. That's the first time I've heard that, the quiet wound. And it's exactly that, guys. You can see with the play there that there is no movement where the skin is connected. And because of that, that's why you don't see irritation. And that's why you don't see hypergranulation that you might see with some of the other types of osseointegration and their treatment of the stoma and the aperture site. So to me, this is the picture that's worth more than 1,000 words right here with this one.
Yeah, mobility and movement at the skin penetration site is bad. It leads to trapped bacteria. It leads to a chronic pistoning that can lead to fluid extravasation. The most quiet wound is the most stable wound. So I made a determination that I really wanted to learn this art from Ricard Brennemark himself, as he was teaching all of us that would come to Walter Reed together. It was a crazy Padawan learnership. It was so much fun.
Yeah, it's medical history. I was kind of describing it to my husband the other day. I was like, technically, he's not his father is the father of osseointegration.
Yeah.
But I'm just like, Dr. Brennemark, you are the father of osseointegration. This is medical history, and we get a front row seat to this.
Just amazing. It's a revolution.
The coolest thing ever to be able to see. And guys, I have to show you my toy. I got one from Integrum, and this is like, my kids love using it for like a blast. Pew, 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 right? Sorry, Jamie. It was too easy, right?
It was coming.
But here you go, right? So guys, I know so many of you have seen my shows on osseointegration, but I do have some first timers. So it is a 3-part modular system. The first part is the fixture, and that's the part that you see implanted in here, right? And that's done in the first stage procedure where they implant the fixture and then they close everything up and let it heal. And that's where the magic starts to happen, where that bone starts to fuse in with that titanium screw right there. Okay, you can actually kind of, you can see why it's called a screw fit implant, right? You can see the rings right there. Second surgery, the surgeon is going to do the opening, the aperture site, and it's been trademarked now as bonded matrix, and that is unique to the OPRA implant system. Only with the OPRA implant system can you do that kind of an opening that you just saw earlier, okay? And they will attach the abutment. That's the part that's kind of sticking out right here, okay? And then the other part, which unfortunately I don't have, but I'm going to petition for that one for next year. It's the AXER device. It's like the black box looking thing that you see, and that's where the prosthetic will attach directly to it. So it eliminates the need for a socket and all of the problems that come with having a socket. And I think I have to showcase Stacy a little bit more here. 6 years ago when I saw my very first osseointegration patient, it was not an OPRA patient. And I said, why the heck would anybody want to do this? I did not know one from the other. And it really is devil's in the details, right?
Yes.
The difference is between these osseointegration strategies and techniques, their treatment of the soft tissue, right? And then I said to myself, well, if someone's doing well with a socket, why would they want to do osseointegration? And folks like Stacy have shown me what an incredible option this is, especially for our above the knee folks. You know, she was an incredibly active individual, and she said herself, by all intents, I was considered to be a very successful socket user. She's a mom. She is into horses. She does a lot of work with horses, riding horses, and was able to do so with a socket. But she said, I wasn't happy. It's still, even when you are successful with a socket, it is incredibly uncomfortable. And I don't have to tell my above the knee viewers here about this, right? All the issues that come with that, having to be able to sit for long periods of time, simple things like taking a plane trip, sitting on a toilet with a socket on, right? So things like that osseointegration now is becoming a tool in the toolbox for the surgeon, you know, to be able to offer patients. And it's now becoming more mainstream care. And that's absolutely wonderful to have that as an option. So, you know, Dr. Alderete, tell us a little bit more about when you're seeing, for example, your oncology patients. How are you screening to see if they would be a potential candidate for OI?
Yeah, it was pretty cool. We had a really good discussion at Gecko about oncologic considerations, or you know, GCCO, Global Community Conference on Osseointegration, on oncologic considerations and where we need to consider, where we shouldn't consider. Mm-hmm. So, and likely we'll find a symposium next year because the acute amputee for an oncologic concern in the right candidacy, in other words, outside of chemotherapy, can find themselves a very good osseointegration patient. There are people that we understand may have difficulty with conventional socket wear, or they have had like one of my recent patients, Rosea's like very astute osteosarcoma survivor, had a fantastic limb salvage for a long time, but because of problems with his extensor mechanism and other, you know, the energy that it takes to walk in some cases with the distal femoral replacement, proximal tibia replacement, it's just daily pain. And in that, our patients are very astute at saying, I pay attention to my immune system. My risk of local recurrence or metastatic disease is now outside of the 7-year process, such that I'm a very good candidate for osseointegration, and I want a different life than a socket user. And it's not it is not the only way. I mean, many people do fantastic in their conventional socket use. Mm-hmm. We understand that people that have shorter amputations, or we understand that many women express to me that they just have difficulty either sitting on the toilet or with a conventional socket. If you have an atypical shape to your limb, in other words, it's not already bulletized or shaped, mm-hmm. A lot of those patients are going to have difficulty with limb salvage. So we understand from a surgical bravery standpoint that there's probably going to be people that we should say, here are your options. I would love to be I would love to be able to surgically present everything objectively. However, quite honestly, you may want to look at this option more seriously and study it, and we'll study it together. Mm-hmm. But for the most part, we are trying to weigh the risks and benefits of time on Earth. So we want to make sure that people from either sarcoma or metastatic cancer are not going to spend so much time in the hospital with osseointegration and potential complications that they would be missing time with family or just getting out in this beautiful world. The other is that we're taking down infection risk. We're wanting to make sure we understand that you probably, as a sarcoma patient, need to be close enough to a major medical center that your surveillance can increase because the risk of infection is greater.
Yep.
Nonetheless, the because these patients are used to, being an amputee is not a temporary process. Neither is being a sarcoma patient. So you're in my registry for life.
Yep.
And hopefully my patients will outlast me as time goes on. But seriously, you're in a yearly registry, and I get to see your beautiful, bright and shining face every 3 months for at least the first 7 years. So in terms of surveillance and risk, our cancer cohorts are a very reasonable patient pool that if they understand the risk, benefits, and options, that we should swing for the fence for them.
You just brought up a very interesting point that kind of clicked in my brain with also something that I heard in one of the panel discussions at the conference we went to, where we were discussing the follow-up care for amputees and how so many of our patients fall through the cracks and what happens when they're not seeing the prosthetist and the physical therapist on a regular basis throughout the year.
Yeah, we had that great discussion.
You just said something right there where you're just like, my oncology, because of the fact that they're oncology patients, right? They are seeing me for life.
Yep.
Right. I know for myself, I have to see I call it my spa day where I go in to see my oncologist now. It's just once a year. Right. But there is always someone keeping an eye on me and, with the oncology patients. But the byproduct is that from the amputee standpoint, they're getting that follow-up care that they need from an amputee standpoint. So I guess my little soapbox moment here, guys, is if you haven't been in to see your prosthetist or PT in the past 6 months, go make an appointment, please. And I'm also going to double up on that is for those of you guys who are my vascular patients, my diabetic patients, if you haven't gone to get the vessels checked in a while, go do so, please. And just make those appointments, get the checkups, have them look under the hood, make sure everything is okay. But I don't know why that just kind of clicked for me there. I was just like, gosh, from an oncology standpoint, they got to be in your office, and that just.
It's really interesting. And Dr. Hsu would echo the process as we didn't do a great job in probably the first 10 years of the war at understanding that limb salvage necessitated the same degree of resource management as advanced amputee care. And then they both are not temporary conditions.
No.
So I have a registry for all of my big gun limb salvage. I have a registry for all of my cancer patients. I have a registry for all of my amputees. They never go away. They're always my patients. And once a year, we will always touch base, no matter what. If they want to say like, hey, Joe, thumbs up, I'm in the Bahamas and I got sand in my prosthetic. Sweet.
Rock on. Keep going.
Yeah. Or like I lost my leg jumping out of an airplane. Awesome. As long as it didn't hit somebody's house like a lawn dart, life is good. But we want people, I want you to break prosthetics. I want you to get out and live. I want you to have difficulties such that part of our program uses advanced analytics and a bunch of stuff to just peel the human apart and say, okay, where are you now? You and I had that discussion at Gecko about core dysfunction and what happens to an amputee, even an osseointegrated amputee as time goes on, because life happens. And even though I mountain bike like an idiot, my right TFL, if I'm not paying attention to it, will light on fire once a week. So I know, and I probably need to have either my therapy brothers or my mountain bike brothers, and sisters say like, Joe, did you do your maintenance exercises? And I know better. We all know better. And it's not like a surgeon knows any better. But life happens. It's okay. You need a 1 year, 10,000 mile, no matter how advanced you are, every year. And because I want to know what your headspace is. And I use advanced amputee care to look in the human being and say, brother, sister, how you doing?
And you do so, and this is the part where we really got to nerd out at the conference. Again, very holistic approach, and you've touched upon that several times this evening. And I think one of the coolest things I was like, you look at nutrition, looking at things like gut health in the patient. It's very refreshing to hear a physician talking about these things. And this is something that I think in our healthcare culture, we're starting to learn more about the importance of nutrition and how it plays a role. And it's not just eat your veggies, drink your water. It goes a lot deeper than that.
Yes, ma'am. I mean, it was kind of funny. We were, my delusion of grandeur was, or one of them, was creating an Intrepid on the outside with a UT Spurs, UTSA, Southwest Research Institute pathway, that the lift was probably too heavy, was definitely too heavy because we imploded the program. But all of the human performance work was left over from Chris Rabago and Katie Yankozik. And when we looked at Joe Shu's Return to Run program, this is long before he's doing osseointegration. Mm-hmm. He helped create a program because nobody brings a better team together than Joey Shu, and hopefully he won't shoot me for saying that. But does a fantastic job of realizing what a gap is, facilitating a team around it to solve that problem. At the time, it was 2011, and we really had a dearth of experience with advanced orthotics for limb salvage. You can't just put a stupid brace on somebody and life is good. We needed a program. Mm-hmm. Face forward, the Return to Run program became R2, or like you tell me, if you don't want to run and you want to just like play underwater tiddlywinks or jump out of airplanes, you tell me what that is and we'll make it happen. And that was R2, which also became the Power program, or the Performance Optimization Warrior Enhanced Rehab, where it was nutrition. Mindset was Mind the Gap. It was multimodality, pain control, and this was all born out of Intrepid in 2015, 16, long before a lot of these human performance efforts were really appreciated, and especially in the rehab space. So lo and behold, years later, I'm retiring and trying to bring this process to San Antonio. You have greats like Peter Attia, who's leading this revolution of longevity science and medicine 2.0. In other words, like, stop putting band-aids on people. Like, get what a good friend and former SOCOM medic Paula Datura would determine left of bang. In other words, get way left of the parachute opening or having a problem, and make sure that everything is squared away before you jump out of the airplane. And it's the same thing in medicine. So we look at nutrition, mindset, what your immune system is like, this whole human performance migration to the medicine setting. And we were creating the idea of a human digital twins use in optimizing not only special operations performance, but also my advanced amputees performance. So if we're thinking about how do you, from a nutrition standpoint, what do you need to really develop a good cookbook around? I need to understand what my insulin resistance is going to be like, or what my insulin curve is going to be like. Yep. Personally, for me, that was getting really nerdy into the GLP agonist, and facilitating. I had a couple of experiences where I drugged my glucose curve so low that I couldn't speak after a 3-hour mountain bike ride.
Yeah, that's probably not too good.
So, we all do. My wife thought I was intoxicated as I sat in the car, and my mountain bike partner was like, "Hey, Joe, you're looking great. uh, like, do you want me to take you home?"
Let's get you an orange juice, shall we? Let's get you an orange juice.
Oh my God, yeah. But it's funny. We should only be so courageous as to take on certain experiments as an N of one. In other words, ourselves, right?
Yeah.
So it is what it is. From the standpoint of also our aging, and you don't have to be like, certainly I'm 53 and aging. So understanding that my protein levels have to far exceed what should be in the daily requirement, and I should be at 1.6 grams per kilogram of body weight per day, but probably more like 2.0 if I'm going to keep going, and my kidneys are going to figure out the how to deal with it, so that you can minimize your inflammatory process, because I never want you to miss a day as an amputee of training, because otherwise then people develop postural scoliosis, or their glutes get out of whack, and suddenly we have to do a bigger 1 year 10,000 miles. But also the gut microbiome, as you were mentioning, we were talking about over the weekend with your family's own story. I mean, for me, gut microbiome can be everything from you determine how well you respond to stress cognitively. It is certainly your immune system. It's how you respond to if I need to use antibiotics from time to time, and then what your energy metabolism is going to be like. So we get really nerdy. Obviously, big vision is to put a whole institute around this. Conventional medicine may or may not be able to see that, and that's totally fine with me. I can do it via a number of other vehicles. But everything from nutrition, very, very heavy into Headspace and Michelle with On Healing. Every program will not have university or institution homogeneous resources. So this community has been awesome about hearing Ashley Bloom's calls, my wonderful PA and first sergeant, and somehow this young orthopedic oncology PA does a fantastic job of managing the angry colonel, and she has this whole community behind her of, hey, Dr. Alderete says we need trauma psychologists or limb loss psychologists, and certain systems may not understand or can't afford it because they have so many other things going on. So, Michelle and On Healing have said, we want to be your answer to this. And oh my God, did they dive in with limb loss psychology. They see all of my osteointegration patients, and frankly, all of my amputees, because everybody has been placed on narcotics, which I think are the tool of the devil. And I'm probably going to get sued for that, but that's okay. No. I mean, you see how many of your patients cannot be motivated because we doctors Joe Alderete has poisoned them with Percocet. So,
yeah. No, I have quite a few patients. It's not just the pain medications; it's the polypharmacy, and we talk about this a lot. It's because I have direct access. So what that basically means is my patients can come to see me without a doctor's referral, which means that when I evaluate them, my history and physical on my patient needs to look almost like a doctor's.
Yeah.
And part of that is reviewing medications, and they'll bring to me 30, 35 medications being prescribed by 5 or 6 different doctors, and no one's talking to each other. And
Nope.
I have a laundry list of stories of people on 5 different blood pressure medications, 5 people on enough pain medication to knock out an elephant, and people really struggling.
Yes.
And it's all very well-meaning doctors, very well-meaning. But a lot of times with amputee care, especially with pain management, we get doctors prescribing medications that are not familiar with amputee care. So they'll start them on a very high level of gabapentin. Instead of exploring a lower level, perhaps with other more conservative techniques. That's we've done lots of shows on that. And
holy cow. Yeah.
It is a problem. And, having that kind of amount of medication in the system combined with everything you mentioned about nutrition, it's going to impact the well-being of the individual. And having that approach, especially when you're working with osseointegration, right? We want to keep, just what we talked about with that beautiful bonded matrix, keeping that skin healthy, preventing infections down the line. There's what the research says about the infection rate with OI, right? And then I'm going to step aside and just say what I see with my own 2 eyes, and this is just me on my own, is the OI folks that I've spoken to that tell me they've not had problems with infection. When I look at their lifestyle, that tells me a lot about why. Number one, that they had the bonded matrix, so they just have a much closed, much more tight system to not allow bacteria in. That's a huge part of it right there. But then I look at how they take care of themselves, how they take care of their skin, how they take care of their bodies. So I'm actually really looking forward to some of the more long-term research when we start comparing people's lifestyles, and how much medication they're on, ancillary medication that they're on.
Yes.
Right there. I'm going to pause for just 1 minute. Guys, we are coming close to the end of the show. We need ourselves a winner. So we're going to post one more time, and I'm going to post, I think I got a fancy little QR code here. I got to be fancy. All right.
It's better than me. I'm a digital chucklehead.
Oh, believe me, there's a lot of tech people right now in Detroit going, Kosi. You can hear the head slapping right now. Guys, there's a QR code there right now for Integrum's TikTok channel. Show them love. Again, we want to keep this going. We want to keep this show going. I know I sound like a PBS commercial special right now, but go ahead, show them some love. Follow them on TikTok. Follow them on YouTube. Amazing videos, wonderful interviews with all of their Integrum ambassadors, many of whom have been on this show already several times. Dr. Alderete, I want to get a couple of these questions that were sent in.
Yes, ma'am.
So let's see. Oh, this person sent in a lot of great questions. What is your long-term infection prevention protocol? And I think I already know, based on what you've already talked to us today, I think I know the answer to this one. And how quickly should I report any skin irritation or if any drainage is present around the abutments?
Most of us are going to say you're going to get 2 or 3 superficial infections a year. There are protocols that the Danes and our Aussie colleagues have that are not FDA approved in the United States, but the ability to take care of your skin at the skin penetration site, even with that, means that you're going to be pushing that bonded matrix environment proximally to make sure, and don't be afraid of it. Just taking care of a denture, you get used to, and heralding back to Professor Brennemark himself, taking care of that environment, pushing that environment back, very much like an X-Fix pin site, and making sure bacteria is not trapped. And then allowing it to facilitate through without using any noxious chemicals around the skin penetration site. Because remember, we just simply want to create a very quiet wound. And that full thickness skin graft, that zone of absolute stability that is the bonded matrix process, takes a really, once healed, takes it very little work.
Yep.
Most of my irritations, because it's truly it's a stomatitis. If we're managing, like if I know what your glucose curve is like, and I know you're not like binge eating Twinkies, then I know your stomatitis, skin irritation, is going to be such that when you call me and say, "Hey Joe, I had a little increased pain, I had a little increased drainage," it mainly is step off, so a little periostitis. I'm not having a great deal of loading, and the abutment does not move. And my patients know, no antibiotics. I watch it for 2 or 3 days. I allow that periostitis to relax. I reevaluate at 3 days and make sure that it is resolving, and then we resume weight bearing. If there's continued drainage beyond that, I will run your inflammatory labs. I learned from a dear mentor here at UT Health that facilitated this process called immunoresilience of looking at your albumin globulin ratio and looking at IL-6. So I really want a Polaroid of what your immune system is seeing. And then I know no matter what's going on of cellulitis or stomatitis, your immune system is strong enough to do what I'm asking it to do. So most of the time, I don't want to put you on ridiculous antibiotics for a week. I just try to manage this through the immune system, and hopefully in this idea of polydituro leptabang.
And that's what I like to hear. No, that's an amazing question. Pam, no worries if you're not on TikTok, just because I am. All right, here we go. I know. So we've got a YouTube channel right there, guys. And this is also Stacy's story. So if you don't have TikTok, follow them on YouTube. We're going to announce our winners in a couple of minutes. So here's another question that came in. It says, what are your expectations for activities like driving, uneven terrain, or even light running? Are there precautions for swimming, hot tubs, or saltwater environments?
Probably one of the people that taught me most about this environment is one of our oldest patients in the DODBA osteointegration study was my former CFI pool therapist. And she had difficulties with her prosthetic for years, chose osteointegration, absolutely destroyed it. She has had, more complications. Kara had a femoral neck fracture. Again, most of my patients know that I cheerlead for them so dramatically. I will, by praising and cheerleading for them, I'll say your name on stuff. But that skin penetration site is so tolerant of salt water. I say chlorine or pool water. I have people, again, we're facilitating the quiet wound. So if you notice that kind of peau d'orange look around your skin penetration site, like your hands are getting a little too moist, then you get out, dry, chill out for a little while, and then get back at it. Salt water is the same way. I don't like it to stay encased in water for a significant period of time, but I know some of my osteointegration patients have socket transition modifiers that will, they have basically a thinning leg that is protected from the salt environment, even though they may have a wetsuit on, or they simply spend 15 minutes in the salt environment or 20 minutes in the salt environment. They get out, they dry, they take care of their skin penetration site, and then they get back in. That's fine. If I'm going to run patients, and this is where it's a little bit of madness, and I'm okay with it. We don't know enough about the host prosthetic junction, and we will understand as, like, maybe I can beat down the doors of my NASA colleagues down here in Houston. I need a strain monitor for the periosteum right outside of that host prosthetic junction. To be able to say you can put a phone on your leg when you're walking and then running, and I can see that your strain is not going to be exceeded. In the absence of that, all I have is pain and the periostitis the next day. So what I do in people that want to do a light jog as they're playing with their kids, like thousands and thousands of repetitions are probably a good way that we're going to get into having to do an early abutment exchange. So I don't want you to do that. So, but from the standpoint of, I use the AlterG treadmill unit. Once you've got a good gait, and like Cozy, I learned this from you guys and all of my intrepid therapists, and like what can get people back to elite weight bearing with good form, because like running isn't just running, but with good form, so I can minimize that force. If they have minimal pain with complete gait resolution back to 100% weight bearing, I say, okay, we're going to work on a light airborne shuffle.
And I'll tell you what, I have not had the chance to do that because I don't have access to the particular AlterG type treadmill. But for me, I just kind of froth at the mouth thinking about that because, in working, I'm like, oh yeah. In Integrum sitting there going, why did we let her talk on the show tonight? No. But basically, it's just, one of the things I love about osseointegration is just seeing the alignment. Where's Bob? Have you met Bob? This is Bob. He's my reluctant and very snarky patient model.
I love it.
Basically when you have a socket, that femur is just kind of swimming around in there and it's like popsicle stick in a Jello mold.
Yeah, or a bucket.
With osseointegration, they were taking the end of that femur and fixing it right where it's supposed to be. And so the gait pattern can just be that much smoother in the alignment and the biomechanic. That's the nerdy part for me. So I can only imagine. I mean, obviously, folks cannot go running. Let me put that out there, guys. You're not supposed to be running with osseointegration. Let me put that out there. But if there ever came a day, and in the AlterG treadmill, where your weight is being supported and you obviously are not putting that kind of pounding on the abutment, could be kind of cool. Casey says, love the airborne shuffle. Haven't done it since maybe 2018. Casey, by the way, I just want to congratulate you. I just got the text. You are the TikTok winner right here. So thank you again for supporting Integrum. And then John C., my boy John C. right there, he is going to be our other winner this evening. So guys, I know you both know my email, but I'm going to go ahead and put it up there again, because this goes for all of you. This show is for those of you in the amputee community, whether you are an amputee, a caregiver, or family member that supports your amputees. That is my email address right there. So if at any point you have any questions, and if you have a question for Dr. Alderete, if you have a question for the Integrum team, please feel free to send me that email. I answer all my emails within 48 business hours. Casey and John C., please send me your addresses so that Integrum can send you a very nice swag bag. And to my winners for my last show, we've had 2 very close shows with Integrum. You will also be receiving your swag bags at the same time. We thought we would do a general mail out instead. So we were going to be doing that. And guys, I could keep talking all evening with Dr. Alderete.
I'm right there with you, boss.
A lot of fun. This is a lot of fun. But we do have to part ways right now. People are always like, how long is going to be your show? And I'm like, last man standing. So guys, I do want to say a very special thank you. I know we had some internet glitches this evening that were out of our control, but we got back on track. So thank you guys for sticking around. Once again, to all of our veterans, men and women out there, thank you so much for your service, Dr. Alderete, obviously yourself included with this, and for taking the time to be with us this evening, taking time away from your family. So we really, really appreciate it.
My honor. What a great crew.
All your knowledge. And guys, if you are anywhere within the San Antonio area,
please.
This is the guy you want to see right here. His amazing team, which hopefully next time you're on the show, we'll get to have your amazing team on the show as well, because they truly are.
I agree. I'll shut up. They can just talk ad nauseum because they are some passionate people.
Fantastic. And once again, thank you to the Integrum team. Everybody from the Dr. Rademarks to Jamie and Carrie and Jen English. You guys are just an absolutely wonderful support. Yes. Thank you for all your hard work behind the scenes and for keeping this show going. Thank you. Thank you. Thank you. All right, guys, as always, thank you for letting me be a part of your lives this evening. I will see you next week. Same bat time,